I don't know what happened there, guys. Apologies for that. So we're just basically talking about what paramedic practice leaders do. What's our roles? You've not missed much if you've just joined us. It was an open question to everybody online, but we were just kind of going into some of the details of what we do as part of our clinical leadership role. We work with the medical directors in our region. So between myself, Oli and John, the province has been divided up into the health authorities. So Oli looks after northern BC and Vancouver. I look after the interior and the Fraser region, and John looks after Vancouver Island. So if there's any clinical incidents or events where the medical directors and or operational directors in PCD need some support, then we are there to offer a paramedic perspective on that and also move practice along in those areas. Now the EPCR system is getting more established, we're also getting involved in the clinical audit of EPCRs. So part of our role looks at the PCRs and establishes if the care bundles have been given, and also make sure that we look at clinical documentation of these PCRs and make recommendations to crews and educators in each one of those regions. We are also encouraged to reach out and get involved in research opportunities, be it paramedics. We've had a couple in the last 2 or 3 weeks have engaged us who are participating in their BScs or in their master's projects, who all want a research study to go at. So we're connecting those in with Peter Thorpe now, and right now the community paramedicine team, to see if we can include that as part of their evaluation. So kind of as a snapshot, that's what we do. But at the super high level, essentially we provide clinical leadership across the organisation, and we bring a paramedic and professional practice perspective to decisions that have been made. So previously these are decisions that may have involved certain paramedics, but for consistency now within our group, we're championing paramedic practice, and it's been approached from our experience in the field and on the street. We also maintain a clinical presence in the field. So part of our role is 1 day a week to make sure that we're out with all the frontline staff, doing calls, listening to their experiences, listening to their feedback, and also kind of seeking information that we can take forward to our leaders in the organisation and provide that real information forwards to, again, make good decisions with. We also help inform organisational change in clinical scope, and we'll go a little bit more into that as we talk about the clinical practices that have been developed over the last 12 months. One way in which we're going out and engaging staff is also through our clinical and professional practice Townhall Meetings. So over the last 6 months, our team have been going around the province, and we started in Victoria. We've been to Prince George and joined Dr. Spooner and everybody up there. We were recently in Kelowna, and the next one scheduled for Nanaimo in January. And so that's your opportunity as employees and as paramedics to come and meet us in person and actually have face-to-face discussions, so we can hear about your concerns and areas of practice that you feel you would like to see to improve patient care. So far we've had great engagement with this. We do our best to promote it on Facebook and on the BCEHS SnapComs as part of our communication strategy, but we want to hear from you and make sure that it's valued and you enjoy coming. So we talked about clinical leadership, and what I kind of want to touch on is what we call the 4 pillars of advancing practice. So to advance practice in any organisation or in any culture or any discipline, you need one of 4 things. You need good clinical practice, you need facilitated learning, you need leadership, and you need evidence-based research and development. Without any one of those, neither can really progress forwards in terms of changing or advancing practice. So we talked about the clinical leadership aspect of it. But what underpins all of those 4 things is professional practice. So you need all 4 of these to be viewed as a profession and to be driving change forward. So how is that being done currently in BC and across Canada? Well, the Paramedic Association of Canada have released the Vision 2025 position statements on bachelorette entries to paramedic practice. We've got the EMALB regulation workshop. So our team works closely with the current regulator in BC to look at how we can develop and push out professional standards of practice in the Code of Ethics and also in scope. We've got the continued competence and continuing education credits. Currently that's 20 patient contacts and 20 continuing education credits, but we need to move to more of a professional portfolio-based competency and education. And we've got clinical practice advancements and communication. If anyone's got any questions, please jump in as we go along. So one of the main pillars is learning and education, so facilitated learning. So right now we see the role as paramedics still in BC as that technician, vocational, skills-based approach to patient care. And we want to push this forwards with education to more of a clinician-based approach to patient care, where we're established as a clinical profession, which is self-led by paramedics. So what's the journey that we need to go through to achieve this and get there as an organisation and as individual paramedics ourselves? Like I said, PAC have released a position statement on Vision 2025, which basically calls for all paramedics across the province and the country to receive PCP entry at diploma level and then hopefully ACP at bachelor degree level. And that will open up opportunities for paramedics in the future in relation to master's degrees, PhDs and other higher educational qualifications, which you could do to drive practice forwards. There's also been a position statement that's been released in America as well about the need for paramedic education moving towards degrees. So this isn't just a Canadian thing, it's kind of a big North American movement. We've got a question in the room.
About funding for this, if I would like to receive my diploma and move forward with that, is there any kind of funding from the service?
So the question was, if people couldn't hear it, is there any funding available currently for this education for our existing employees to go forwards with maybe achieving a diploma or a degree? Short answer is no. The PCP and the ACP programs are both can be both funded at the moment by students who seek foundation money for their course fees. Obviously, we understand that there are barriers to further education, and at the moment, one of the big ones that we see for staff is the ability to study part-time and earn an income and salary. As more and more positions open up, there may be more opportunities to personally invest in a diploma or a degree, which you would then get back as you progress your career going forwards. But currently at this time, BCEHS is not able to fund paramedic diploma courses. There are various pathways for staff to access diplomas right now through the Justice Institute or in partnership with the Thompson Rivers University pathway, so you can get a degree in health sciences. That will set you up for the future, but right now, yeah, nothing exists for funding, unfortunately. What are we doing internally in relation to trying to improve education and access to information for our employees? So currently we've got a podcast series which has been developed by a gentleman called Gord, who's one of our members of staff, and Floyd Besser. I think there's been 3 or 4 episodes that have been recorded currently for release in the new year, and it's called Medic Minutes, and it's the BCEHS pre-hospital podcast. Once more information is available about this, it will be heavily promoted, and all staff will be encouraged to tune in and listen to the various topics. And it's going to be all ranging. It's going to be looking at dyspnea, it's going to be looking at trauma, SMR guidelines, practice updates, it's going to be looking at ACS and STEMI care. It really is going to cover all license levels, and we're going to do our best to take it to a depth that's appropriate for everybody, but we also want to make it informative and enjoyable to listen to as well. Obviously, we've got the BCEHS UBC rounds, which are hosted the third Friday of every month. So we're all on board now. I was actually just having a chat with our colleagues in the room down here about how we could potentially better promote this and get more participants and more active engagement. But hopefully you'll find it valuable. And again, we'd like to hear your feedback about ways we can expand this initiative and make it more enjoyable for the people when they're tuning in. And then there's a continuing education for EMALB. So currently people might be aware that EMALB have had a recent change in leadership themselves, and they're catching up on some work that they really wanted to get on top of, and that includes auditing paramedics. So this isn't something that you should be fearful of or scared of. It's a license requirement, but all they're wanting to do is ensure that you've tracked your education appropriately and that you've got the required amounts of patient contacts that are stipulated. If you've got any issues, I would reach out to your paramedic practice educator or even one of our team if you receive a letter. All your transcripts should be available on Learning Hub, and they just want to make sure that all that information is collated in such a way that they can review it. So it's not something that people should be fearful of.
Somebody's mic is open and they're typing.
Someone's typing in the background. Could they just please be mindful and mute their microphone, please? Thank you. So what we want to push towards is more of a paramedic professional portfolio. So this would include reflective accounts of calls that you've been on. So not just as simple as recording the time and date of the patient contact that you had, but what type of patient contact was it? What did you do for the patient? What was the clinical care that you provided? And on reflection, what could we potentially have done better? Not just from an individual perspective, but from a system perspective. If you'd had a certain drug, would that potentially have improved the patient outcome? If you'd had access to better assessment skills, could that provided you a better opinion of what was going on with the patient? For example, 3-lead and 12-lead ECG for PCPs. These are things that we're consciously aware about. But again, as more and more people talk about these things and these gaps in practice and pull it together professionally, we can actually start to advance and push forwards these changes in the organisation in paramedic practice to BC. And we've got a huge culture shift that we need to do to achieve that. So we need to move to more of a health professional approach, which is underpinned by that foundational education in relation to diplomas and degrees. So we've covered leadership, we've covered education, and we want to now cover evidence and research and development. So research and evidence-based practice. What is it? Does anyone want to throw out their ideas of what research and evidence-based practice is? Anyone in the room here?
Change to your practice based on factual information that renders real-time results.
Did everybody get that? We're going to say a bit louder.
Changes to practice within our scope created by research facts that render real results.
Anybody else want to add? No. Okay.
Hi, from George. I would say evidence. So the opposite of evidence is anecdotal, based on anecdotes.
Yeah, absolutely. So we want to step away from this anecdotal culture of informing practice to actual evidence-based practice. And it's kind of, what is evidence? So it is a broad sweeping statement when we say evidence-based practice. And most people pull into literature, into journals, into articles, but evidence-based practice is the conscientious use of current best evidence in making decisions about patient care. So that's the evidence that you have in front of you at that time, but equally the evidence that we as paramedic practice leaders have in front of us in terms of our decisions that we make. So evidence could be anything from a journal all the way through to CAD information, all the way through to your siren data, which is why it's really important that people document their patient care well, not just for our sakes, but also to ensure that people clearly understand what care patients have had on their journey and through their experience. Currently in BCEHS, we've got a number of research studies that are currently underway. We've got the CanRock Frontier ECPR trial, PAIN-K for the ketamine, which John can speak to. We've got a paramedic-led resus study. We've got the Rural Advanced Care Paramedic Implementation Study, an airway register, the ketamine for excited delirium, paramedic taxonomy and database, and opiate overdose response for paramedics. So the CPSS is the Canadian Police and Safety Security, which is a Canadian national-based organisation. We've been awarded a grant of $998,000 to develop a national paramedic taxonomy and a paramedic database nationally. And that's currently been led by members of BCEHS and part of our team's responsibility. Equally on top of that, due to some research and studies, we've been awarded a grant of close to $1 million for our palliative care initiative. And that's an initiative that seeks to improve palliative care for patients across the province. And we'll be looking at pulling some research out of that and looking at pockets around BC in which we know we could provide better care for patients that are experiencing these episodes and that are registered as palliative or maybe not registered as palliative, and bring them into that community practice. John, is there anything you want to speak to in relation to the studies currently for the ones you're involved in?
So the ketamine for excited delirium, again, that was sort of a study as a soft way of putting that forward. The evidence about ketamine's use in excited delirium, there's overwhelming evidence to support its use for excited delirium. So that research wasn't so much to determine if ketamine was the appropriate pharmacology to go with. That was more, I think this is an important point to make because we'll be doing a lot of this in BCEHS, is sort of soft rollouts and determining, working out the logistics of implementing something like that in the field. So ketamine for excited delirium, we started in the island, we went to the lower mainland, and now we're just in the process of going province-wide and training ACP paramedics for the use of ketamine. And the same thing with the intranasal ketamine, whereas that was tried, its efficacy was supported, and now we're working on rolling that out as well, province-wide.
Perfect, thank you very much. So how do we tie all this together in relation to clinical practice? So we've got clinical leadership, research and education, and now we need to pull it all together in relation to moving clinical practice forward. So John will go into explaining this as an example, but currently these are the steps that we take as practice leaders and within our team to push practice forwards within BCEHS. So we look for a recommendation, and that's been driven by the analysis of evidence. And that evidence, like I said, comes from either literature or comes from data that we as BCEHS own. We then draft the change, which gets taken forwards to Clinical Medical Programs group that meets once a month. And there it will either get approved or further recommendations will be made before it can advance. We then look to determine budget and impact and plan in relation to procurement and patient care delivery. We then determine what the impact to education might be. So how could this change or this scope best be implemented? Could it be face-to-face? Could it be an online module? Could it be delivered through the PPEDs or the instructors? We then look at initiating new treatment guidelines. So they're drafted by the paramedic practice leaders and their medical directors, and then get implemented into the handbook. And when we're ready, they get approved and they get turned on. And then we initiate the education. So one of the shifts that people will have seen most recently is once you've now been educated in a new guideline or in a new piece of equipment or in a new piece of or in new medication, rather than having to wait for the whole province to get their education, if that drug or that medication or that equipment is available to you, you can start to practice with it immediately. So that's been a bit of a shift in the way that we've been operating. And then we monitor that change, like I said, through clinical audit, through the data in Siren, and we adjust as needed. And John can give us an example or a couple of examples of how some of the most recent clinical practice updates have gone through this process and now are being practiced by paramedics.
Yeah, so there's been a number of them that would be good examples here. So the epinephrine for croup, that's coming to the PCP level. So it's followed all these steps where there is a look at the research and the evidence supporting it, and a recommendation taken to medical programs saying that we should take nebulized epi to the PCP level. And then from there, we just follow these steps that are on the screen, determining the budget and impact and how we're going to provide that education, and if that's within the budget. And that sort of leans towards what Leon was talking about with regards to sort of segmented deployment of this. So rather than waiting until we can have the entire province trained before implementing a new practice or a new guideline, we'll work on various areas. So for instance, right now we have the AIM-3 training. We've had 2 classes to date, one in Prince George and one in Vancouver. So rather than holding back a guideline until the entire province and all the ACPs are changed, it's just as you're trained, you'll be given the green light, the go-ahead to practice these new guidelines. And you'll start to see more of this too as we move into, Leon's going to speak towards our new clinical practice guidelines, which we're working on in 2019. And I think you'll start to see a lot of this where there's a very broad scope of practice in the guidelines, and you'll be practicing whatever it is that you're signed off and have been provided the education on. You'll be good to go with those various guidelines. So you'll see lots of new changes in the new practice guidelines. Other things on here, again, we just all followed the same process with all of this. If we look at the recent change to nitroglycerin, again, that's something, a small change we made at the PCP level for administration of nitroglycerin, and that a previous prescription wasn't required. So that's another good example of a recommendation that came forward. We looked at what is the best clinical practice in the pre-hospital setting, what does the evidence show, what does the research show, what are the logistics involved in providing training and getting the messaging out province-wide, and then implementing that change. So it's a bit of a drawn-out process, but it's something that our team is dedicated to, and we try to speed that process up as much as we can. And again, FastVan, you're all familiar with the FastVan, and that's something that we're still deploying, implementing province-wide. So again, we have FastVan bypass criteria for the southern Vancouver Island, and we're looking at regionally specific areas in developing unique guideline criteria for those areas based on proximity to tertiary care or to definitive care centres.
Perfect, thanks, John. Anybody got any questions so far? Okay. So, bit of a recap on some of the clinical practice updates and changes that have occurred in the last 12 months following that process and led by Joe and the medical directors and our team. So, breaking it down, airway and breathing. So, there's been the introduction of iGels, like John said, as part of the AIM training. We've got the MDIs for BVM and CPAP. We've had new CPAP devices. John mentioned the epinephrine for croup. So that's been currently trialled on the Sunshine Coast. We'll review that information and then we'll make a decision about how best to take that forwards. Ketamine and phenylephrine for intubation. Now, John can probably speak to this a little bit more. It's part of the AIM-3 education for ACPs. John?
Yeah, so I touched on this a little bit. This is one of the biggest practice changes we've had in a long time, and long overdue is the use of ketamine and phenylephrine for intubation. So the ACPs will this will be implemented in their practice once they've completed the AIM-3 course. So basically, if you're not familiar with this practice change, whereas we used to use midazolam as an induction agent for intubation, we've moved to ketamine. Again, and this is based on the current evidence for pre-hospital airway management. Ketamine as an induction agent. Ketamine will also be used for not only excited delirium, but we'll be using ketamine for procedural sedation and analgesia in the field, and that's all as well part of the AIM-3 course. And phenylephrine for blood pressure support in peri-intubation, pericardiac arrest scenarios, and that training is also part of the AIM-3. So all this will be in place very soon.
Thank you. Oh, we've got a question in the room here.
Will the iGel be included in all the upcoming courses?
So the question, John, was, will the iGel be included in all the AIM-3 courses?
It is a part of the system.
Yeah, so the iGel, it will be included in the BLS AIM, the ACP AIM, as well as the anywhere where there's a airway component. So, for instance, the PEP course and the ITLS course have an airway component to them. So the learning department will be integrating the training of the iGel into that. There's also a professional development day, which will be coming out in 2019, that the learning department is going to be providing, and that will include a lot of the things we've listed here that Leon's just put up, the MDIs, the iGel, the croup or epinephrine for croup. All that training will be available through that course. And the scope for the use of the iGels at the PCP level will be expanded as well. So right now it's for the King Airways just for cardiac arrest or post-cardiac arrest management, whereas we'll be, or rather the learning department will be providing education to expand that scope of practice for unconscious patients, and the specifics of that will be to be determined.
Okay.
I'm taking a course in January, and I'm just wondering whether I will be educated.
In the iGel? Yeah, more than likely. It sounds like you will be, yes. So moving on to other clinical practice updates in the last 12 months, cardiac and stroke. So John's going to speak to some of these a little bit more as well in detail, just in case you're not aware of them. But we've got a STEMI bypass initiative that's happening in Kelowna right now with ticagrelor and heparin. We've got pre-hospital TNK trial happening in Kamloops. As John mentioned, we've got the change to nitroglycerin. You may or may not be aware, we've got an RFP out right now, so that's just a contract that goes out on the government websites for our defibrillators and monitors. That's both at PCP and ACP, CCP level. And the fast van tool and stroke bypass. So, John?
Yeah, so these are really exciting changes in cardiac care, and this is not groundbreaking territory. This is, again, something that's currently being practiced. For instance, in Alberta, the use of ticagrelor in the field, and TNK for that matter, has been going on for the greater part of 10 years. So we're looking to other agencies that have already put this into place and worked out all the bugs. So the first one, the STEMI bypass in Kelowna, a good example of working with various health authorities to improve patient care, and that's exactly what we're doing there. So the Kelowna ACP group are working with the health authority to implement this procedure to give ticagrelor and heparin in the field, and then in these STEMI cases, bypass, for lack of a better word, the emergency department, and just to expedite the transport up to PCI, up to the cath lab. And in Kamloops, we're looking at TNK, so tenecteplase in the field, and that's another initiative. We'll be working with the interventional cardiologists and the hospital in Kamloops and Kelowna, looking at TNK administration and transport to PCI from there. Nitroglycerin change I touched on, that's just to do with the EMRs and PCPs about no longer needing a prescription in order to administer it. And there's a full practice update regarding that if you'd like more details on it. And I've already talked about FastVan and stroke bypass. So you'll see lots more information. That's a huge initiative province-wide, is stroke care that we're working with Stroke Services BC on very closely on improving stroke care, specifically with respect to bypass criteria and getting these patients into CT and into definitive care inside of that 6-hour window.
Perfect. And so an initiative that our team is involved in with the Siren Group that's just started this month and will go on till March is how we can look at all this information from a quality assurance perspective. So as I mentioned, part of our role is to look at this data and look at how we can improve practice and ensure that standards of practice have been met. And so the easiest things to kind of compare there is in relation to ACS and STEMI care. We need to make sure maybe that the patient's had ASA, that they've had nitro, that they've got appropriate analgesia. Before we've given that analgesia, have we established a pre and post pain score? Have they had a 3 lead? Have they had a 12 lead? What did that say? How did we transfer the patient? Where did we transfer the patient to in what time? They're all key performance indicators from a clinical quality perspective that we will be aiming for as part of this. And that will be getting integrated into your tough books, into the Siren program itself. So if you were to miss any one of those key pieces of information, you'll get a notification or a score or some type of display that informs you of what it is that you've missed. Another example might be stroke care. We need to make sure that the patients had their FAST test done. Have we checked their GCS? Have we recorded what that GCS is? Again, for continuity of care. So when they get to the ED and they get to the CT scanner, they can see if maybe the patient started to resolve or if the patient's deteriorated in their conscious level. That would also include ensuring that we've taken blood glucose readings on stroke patients because we know that they're mimic. So these are all things that we kind of may be doing in our practice now, but we'll be shining a light on them in a different way that gives us clinical performance indicators of how well we are as paramedics doing this care. And if there are gaps in practice, we can ask the question, why?
So Leon, can I just interrupt for a sec here?
Sure.
Because you bring up some really interesting points, and I think it's a good segue into just understanding what the paramedic practice leaders, one of the important roles we have is integration with the various stakeholders in healthcare. So I mentioned about the various trials that are going on, how we're working with regional health authorities, we're working with interventional cardiologists. A lot of the practice changes that we're seeing in BCEHS and the ones that are coming through or you'll see in the clinical practice guidelines, these aren't decisions that are made between Leon, Oli, myself, and Joe sitting around a table having coffee. These are decisions. There's multiple stakeholders involved in here. If we look at the FastVan criteria, we have a number of physicians involved in the decision-making process. We have, as well as Stroke Services BC and committees that we sit on where this is discussed to the nth degree on what is the optimal care that we can provide for stroke patients in the various regions. And same thing with any changes to cardiac care, stroke care, the opioid crisis and the take-home naloxone program. Again, that was something developed with a lot of work with the BC CDC, and the deployment of those kits is in conjunction with BC CDC providing those and helping us out immensely with that initiative. So there's a lot of moving parts, a lot of players involved here in the decision-making process and in the implementation.
Thanks, John. And just building off that, what that allows us to do going forward as an organisation is once we can report out on these care bundles, it's not just internal within our organisation. We can compare against provincial standards across organisations, and then we can compare against national standards. So we can actually have some hard evidence in relation to what everybody should be doing in best practice across Canada. So we could have a look at how we're doing in comparison to Alberta, how we're doing in comparison to Nova Scotia, how we're doing in comparison to Australia or the UK. These clinical performance indicators, and like John says, provincial best practice, are almost international best practices as well. And it gives us some gravitas to kind of really go forward and champion our paramedics and champion the organisation and look at how well we might be doing in some areas, and equally how we might need to improve patient care in other areas. So I can kind of segue into trauma, and Oli would normally speak to this, but like John said, there's provincial groups, and Oli sits on Trauma Services BC. So a lot of our trauma updates have come from, again, physicians, and have come from bigger working groups across the province that look at trauma care and how we can better improve that for patients. So you may have seen the latest update to the SMR. So there's been an SMR guideline change update within the last 2 months. That is on the handbook to read through. There's been a couple of tweaks to it, but essentially it has been made a little bit more restrictive because, again, we reviewed the evidence, we reviewed patient care records, and we found that in some cases the SMR wasn't being optimally applied, and so we needed to tighten it up ever so slightly. We've got the T-pod that's going to be rolled out as part of ITLS. As John's mentioned, ketamine for excited delirium. And there's been discussion around pediatric IVs up to the age of 12. I think that's correct, John?
Yeah, that's correct. And I just encourage anybody, as if you have any questions about any of these initiatives, I know there's been a lot of discussion about the pediatric IVs, then email us at clinicalpractice@bcehs.ca and just ask us the questions. We'd be happy to field any questions about any of these changes. And again, we're not dictating practice by any stretch of the imagination. We're advocates for paramedics driving paramedic practice. So we're very much a voice of the paramedics in pushing these initiatives forward. And we need to hear from everybody. If there's any issues regarding this practice, then we can clear up any issues by the email.
Okay. Perfect.
And the SMR too, Leon, that's a great example of research driving paramedic practice forward, because for 35 years we've been practicing spinal motion restriction the same way and thinking we're practicing best practice, and then it turns out we're not. And this is international. It's changing internationally as we learn what is the best care for spinal motion restriction and how it changes and why it changes.
We've got the hospital bypass guidelines. So as John mentioned, he's been working with the teams and implementing that for the fast VAN criteria and for stroke. In the new year, Dr. Wilson Wan's been working on the trauma bypass hospital guidelines, and that's provincial. That's been working with every single health authority in establishing what level of patient can go to what hospital and what type of presentations of these patients are acceptable at local, regional, and then bigger trauma centres. So they will be getting released, hopefully, touch wood, in January, if not then early February, as part of our clinical practice update. Big changes to PCP practice, you may have heard the talks on the street, is the introduction of Penthrox, so mefloquine. It's an inhaled medication that we've currently identified 11 sites across the province, which are primarily PCP and EMR stations in rural and remote regions, where we'll be looking at the effectiveness of this medication in relation to the management of pain. We've introduced ibuprofen, acetaminophen, as John mentioned, ketamine, and its uses as well, not just in analgesia but in sedation. Fentanyl is going to replace morphine for ACP practice. And the Penthrox, we are still working through when that deployment is going to occur. The clinical practice guidelines and the treatment guidelines have been written. The education pack has been developed. I wish Oli was here to speak a little bit more to it. He's been leading the development of this for our team and for patients and paramedics across the province. So I won't steal his thunder, but he's done a lot of work into getting this off the ground and meeting with the reps. So I think it's really exciting that we've got these analgesic opportunities and medications available for our PCP colleagues. Any questions on analgesia? Okay. John mentioned one of the biggest projects that our team is going to be working on with the support of the medical directors and other stakeholders in the next 12 months is going to be provincial clinical practice guidelines. So we are going to be, I want to kind of say, hitting the reset button on the look, feel, the information, and the way that these clinical practice guidelines are displayed in the handbook to make it really, really clear for our staff, paramedics and employees, potentially not just in BCEHS, but given some regulatory changes that we proposed with EMALB, these practice guidelines could potentially be in use by all levels of license holder in the province, from FR, EMR, all the way up to CCP. We currently had our kick-off working group last month, which looked to establish the team that's going to be involved in this and all the key stakeholders. And we've been working at creating a taxonomy of patient presentations and conditions that are going to be included as part of these clinical practice guidelines. And we're looking at organisations around the world and looking at how they've got there. So whilst we want to inform our own through evidence-based practice and using the Dalhousie PEP program, we're going to be looking at what Australia have got in their practice guidelines, Alberta have got in theirs, Nova Scotia and the UK, and basically taking the best of the best and making our own super provincial clinical practice guidelines. And what we're kind of hoping that does is make it really clear and clear up any confusion for our colleagues around the clinical practice guidelines and really set out a clear standard of practice that people can follow and people can adhere to within the organisation, so that we can ensure that all patients are getting the same consistent care across the province. And then this will allow us through the clinical audit and through EPCR and Siren to kind of level the playing field in making sure that everybody knows what they are doing, and then that will allow a better mechanism to push change forwards as well. We had a question here.
Yeah. With the implementation of, the CPGS, what discussions have taken place relating around treat and release scenarios?
So it's a good question. Currently, within BCEHS, there is a mandate within legislation that's been agreed upon, in which paramedics in the future, not currently, will be able to look to treat and what we're going to call not release, because we're not fish, treat and refer options for patients. So we're not looking to release patients as such, but we're looking to refer them on to other clinical services and other healthcare providers. Like I said, currently this is practice that we shouldn't be doing in the organisation, because the legislation requires that paramedics need to follow protocols to be able to do this. And within our current clinical practice guidelines and within our organisation, there aren't any protocols in which people can follow to safely discharge patients' care at sea. It's a project that I'm involved in working through with the strategy team and a number of project leaders and our executive sponsors to look at how we can go about doing this. And it's going to start off potentially with a small trial, but we're still working through those details. Essentially, what we'd just like to reiterate is that if patients refuse transport to hospital, that the documentation that you do is excellent and it clearly outlines the reasons why the patients decline transport, and that you are to call clinical and speak to the paramedic specialists. That's part of the process of a patient refusing transport to hospital. And what we've implemented with the paramedic specialist group within the last week or two has been a tool that's been used in other parts of the world for a number of years called the Manchester Triage tool. And this is almost an algorithmic type platform in which it delineates risk to patients based on their presentation. We currently have nurse clinical specialists working in secondary triage using this tool, and it's been used well so far. So we've extended that trial to the paramedic specialists. So when you ring up, you need to be at the patient's side still. So if they've refused, it needs to be a conversation maybe that the paramedic specialist can have with the patient, and so they can speak to them and then they can go through the tool, and the tool will provide an output, and that might be that, okay, this patient could be referred to a GP, and if so, then that means that they are at less risk of anything happening, versus maybe an output that says, no, this patient needs to go to the emergency department, and we need to do everything possible to convince them otherwise in relation to ensuring that they're safe and they get the care that they need. So part of the CPG initiative will be looking at how we can implement some of that stuff in, but like we've said, it's going to be a 12-month project. We're not expecting the clinical practice guidelines to be released until early 2020. And maybe I'm holding us to something that I don't know we can achieve in that time. We think we can get it done. We've got a good team of people, but it will be a part of future state practice, but for only certain patient conditions that we know are safe, low acuity, that can be referred on to other services. So not an independent decision to leave people at home. Is that okay?
So Leon, I'd just like to add to that, in that because your title there is Big Change Coming. I just want to make it clear that this is change in a very positive way, and this isn't going to be an overwhelming practice change for the paramedics to take on. This is going to be streamlining and simplifying our existing process, making our existing guidelines more user-friendly, and providing clear guidelines for things we don't even have direction for right now. So we'll be augmenting our existing clinical practice. And essentially our goal here is not to complicate things and add more to the paramedic's plate, is to streamline and simplify an existing process. So this is really exciting for the team that's involved in this, because we are working to ultimately this will, again, improve existing clinical practice, ultimately make our jobs easier, and provide clearer direction for things that aren't necessarily that clear right now. Fair to say, Leon?
Yeah, that's perfect. Cheers, John. Any questions on clinical practice guidelines? Nope. Okay, so we've talked about the big clinical practice changes in relation to care and treatments that we can deliver to patients. But what does that do for roles and positions and how we can deliver that care across the province? So most recently you may have seen what are new practice opportunities for paramedics. So traditionally there's been roles related to licensure level. So FR, EMR, PCP, ACP, and then CCP. Obviously you've got your leadership arm as well, where you've got the unit chiefs, managers, and now our roles as paramedic practice leaders. But what happens if you don't want to go down that leadership path? What happens if you want to expand your scope and go down a different way of practicing as a paramedic? So new practice opportunities currently in BCEHS have been introduced as a Rural Advanced Care Community Paramedic. So there are 6 positions, 3 of them currently in place right now, 1 at Campbell River, 1 in Cranbrook, and 1 on Salt Spring Island. And there's currently a posting available for 3 of these positions now on the BCH intranet site. So that's in I think Prince Rupert, Fort St John, and in Valemount, BC. And so this is looking at introducing advanced care paramedics into communities and looking at the community medicine side of things, working collaboratively with interprofessional groups, and also providing clinical leadership and support to those regions where advanced care has never been an option before. So all the things that we've just talked about in relation to AIM and ketamine and all the advanced analgesias, those types of care will get delivered to those communities. The role's still being worked through right now, but there might also be an arm to this that allows support of the transfer of patients from these communities to higher level tertiary centres without, if we have the need for weather or kind of like the last couple of days with the storm, we can move them by road potentially as well. So that's a really exciting initiative and an opportunity that's currently taking place in BCEHS right now. There's the Community Paramedic Program, which has been established for a number of years now. again, really great opportunity for paramedics to get embedded into their community, both at that paramedic level, but as part of a team, a professional practice team of nurses and doctors, and providing care at the preventative end rather than at the reactive end, which is where paramedics have traditionally sat over the number of years. And in a lot of communities, we're seeing great success with this initiative. There's been up to 39-40% reduction in calls where we've had active use of community paramedics with these patients in preventing them from calling 911. So really great initiative. There's palliative care. Like I mentioned earlier on, this is going to be a 4-year initiative where we're looking at the lay of the land across BC and how we can improve palliative care for patients around the province. How that's going to be done, we don't know yet. We're still working through the evaluation. All the community paramedics have received some form of LEAP training, what we call for palliative care. So it's a 1-day face-to-face course with an 8-hour module that looks at strategies and initiatives for supporting patients who are palliative and kind of redefining in our minds as paramedics what palliative means. Because we're usually used to seeing people in that end of state, end of life position, and we're traditionally going down the resource path where actually we need to look at more about the right to die and kind of making them comfort in their own home. So I've got a question here. So part of the initiative over the next 4 years is to see how we can look at introducing that education to PCPs, EMRs, and our other employees, and that's just going to be part of the initial scope, the initial probing research that we're conducting. So, like I said, we don't know what that model looks like, and I can't commit as to what that model will look like. The main thing here is that palliative care has been identified, like John said, and we mentioned, as an area of practice that we need to develop, and as such we've got additional funding for this from the federal government, and we can go away and look to introduce different levels of care depending on licensure level. There's a paramedic specialist groups. Obviously, they've been established now for 18 months to nearly 2 years, working as part of clinical, and they're going to be part of the trial group that we're looking at in relation to the referral project. As John mentioned, we've got the opioid crisis, which is still ongoing, and so we've got the bike squad and an OD response. Take-home naloxone kits have been introduced. Maybe we can speak to this in Prince George, but we've also had the introduction of PCP flight paramedics as well, and they've had an extended scope of practice which has been introduced to them, which more information will be released about in the new year. Again, that's a really great opportunity for PCP employees who maybe fancy progressing to ACP. Again, it's opening up other avenues of practice and roles in BC that is separate to your licensing level. And then we're looking at potentially we're not looking at this now, but it's something that we're referring to as extended care paramedics, but the Assess, Treat and Refer initiative. Extended care paramedic comes from Nova Scotia, where they've got paramedics that actively go into residential care homes or actively engage with patients who have been discharged from hospital and provide care to them in their own homes. Any questions on these roles so far?
I just have a question about the rural advanced care paramedics.
Yeah.
Are you guys, with how the program's been going so far, are you planning on hopefully continuing to extend that throughout the rest of the province? Obviously, you've had 3 more positions, but say for like the Sea to Sky corridor or other areas like that.
So it's a good question. I'm not sure if hopefully everyone captured that. Similar to the community paramedic and paramedic specialists and other initiatives and roles, it's all been started as a trial. Mm-hmm. So again, can we get these people in these communities? Let's analyse the data. Are we having good impact on patient care? Mm-hmm. If we are, yes, then hopefully that will inform us of other areas that we can roll out into. Probably just to clarify, there were initially 6 positions posted as part of the trial, but only 3 were filled. Oh, okay. And those 3 individuals are progressing in that role as we speak now. But in the meantime, the remaining 3 positions have been reposted. So it's 6 positions to start the trial with, and then there'll be a review of its effectiveness and also where else in BC they could be placed.
What were the parameters to identifying those 6 communities that would benefit from having this advanced resource?
That's a great question, and one that I'm going to politely deflect because the decision was made before I joined the organisation and before we were put in these positions. So I wouldn't be able to speak to that accurately enough that would answer your question. So I can find out for you though.
And then how exactly is that program working with just one advanced care paramedic in the community? Are they just doing certain hours then? Like how?
Yeah, so they're working, I know one's working in echo shift pattern. And again, but that's all for review. We want to make sure that we get a good cover and good spread of its effectiveness. So kind of whatever it is right now, everything's got potential to change based on review and analysis of the information. That's treat and release.
Code White, Providence 7 Charlie. Code White, Providence 7 Charlie.
We've got a code white at St. Paul's. I don't know what. Does anyone know what that is? Doors are locked. We're all right.
They're in the room.
Perfect. Okay, so we've covered. I'm just looking at the time. So we've covered clinical leadership, education, evidence-based research, and clinical practice. So that's as an organisation what we're doing to move practice along. But ultimately, we have the regulator. We have EMALB. So the current paramedic regulation stands. And why do people think that regulation is important? What's the point of regulation? Does anybody want to jump in? Or I'm going to put everybody in the room here under the spotlight.
To hold people to
Early on.
standards.
From Prince George.
From Prince George, this is Andrew Schultz here.
Hello.
So it's keeping everybody accountable for their practice and making sure that they're following the guidelines that they're provided with. And that whole accountability piece is what I feel is really important in that.
Yeah, so that's a good point. So, again, yeah, absolutely. It's guidelines or it's practice that is laid out by the regulator that can hold people accountable. So whilst we talk about accountability within the organisation and within your role as paramedics, you're also legally accountable to your regulator as a licensed paramedic outside of the organisation. So kind of what I want to venture into here is just making a clear delineation between what your responsibilities as an employee are to an organisation, but equally what your responsibilities are as a licence holder to the regulator or the current regulator, which is EMALB. So yeah, accountability is one thing, but why do we need accountability? What are those practice guidelines there to set? What's the purpose of all of that?
To provide consistent patient care.
Yeah, to ensure good patient care. So we're getting there. So what are we doing by ensuring good patient care? Good. We're essentially protecting the public. So one of the main roles of a regulator is to protect the public from poor practice and from poor patient care. And for all those reasons that you just mentioned there, ensuring that professional standards and that practice standards are set and that are clearly laid out is the role currently of the regulator. Our role of the employer is to ensure that we follow those as best we can and support our employees in following that as best we can by providing some good structure, some clarity, processes, and as John mentioned, the changes to the clinical practice guidelines are going to be a huge part of supporting staff in making those clinical decisions a lot easier and with clear direction. So it's important because it protects the public from us as paramedics. But currently EMALB is run by the Ministry of Health. So we met with them back in September and we held a workshop with them to look at regulatory change. So the current regulation that exists, there's been some tweaks to it over the years, but in the course of 2 days, we sat down with them and we worked very well and very closely to make what potentially some of the biggest changes to the regulation in a number of years. And the analogy that we use is that we've effectively tried to build a 6-lane highway in relation to the scope that a licensed paramedic can operate to. What we need to be clear about is that the employer can then define your scope within the organisation based on what it feels it needs to do to provide patient care. So you could have this amazing scope underneath your license, underneath regulation, but currently you would have to practice underneath your employer's scope and under those responsibilities as your role. But ultimately you're still accountable to your regulator. We're working with the regulator now, and this is where we see it going forwards, to triage clinical complaints and patient safety, PSLS events. So that's not to create fear amongst people, but we're an organisation that's moving to, or is moving and is an organisation of learning. When we talk about learning, we're not just talking about an individual perspective of learning, we're talking about organisational learning and organisational change. So the nitroglycerin change, for example, actually came out of a PSLS event, which was reviewed by our medical directors and our team, which informed the practice change, which has enabled us to provide better patient care, because we heard about these things. And providing even that people self-report through PSLS as well, so they've maybe had a clinical episode where the wrong drug was given or the wrong dose was given, and they've rightly come forward and put their hands up and have said, I've made a mistake, reported it through the PSLS system, and then we as paramedic practice leaders look at that information and approach it from a learning perspective. So those types of complaints or those types of events aren't been taken forwards to EMALB, because we want to manage that and deal with them in-house as an organisation and provide that support and education to paramedics. Where we'll draw the line with referrals to EMALB will be if there's been malicious intent, or if there's been severe malpractice, or from a professional perspective, if it's behavioural or malice, where a patient's been caused harm or the profession's been brought into disrepute, those will more likely go towards go onwards to EMALB post our investigation, because we need to ensure that the public remain protected from that type of behaviour and that type of practice. And currently we see them as our partners in advancing paramedicine in BC. They control the legislation, they control our licensure scope, and if we want to make big changes and big improvements to patient care in BC, then we need to work together to achieve this. Part of our responsibilities, as we mentioned, is claiming these continuing education credits. So we've got BCEHS-led education, PHSA-led education. There's your training courses that you go on, and there's other outside education that you can submit to EMALB for review in relation to those credits. We are working with EMALB under the new proposed changes to the legislation to raise the standards of required continuing competencies to maintain your licence in BC. And that would include a different way in which the credits are currently valued. We know that there's sometimes some inconsistencies in what one thing's worth and what's not, and we also want to try and broaden out the understanding of what paramedic practice is in relation to the type of credits that you can claim for. So example, right now the credit system's set up for mainly kind of skills under the NOC competencies 4, 5 and 6, and you only get half credits for the competencies under 1, 2 and 3. But as we've just mentioned, research, education are big parts of paramedic practice, and if you're engaging in a BSc or an MSc, we feel that you should be accredited for that education in relation to hours that you spend doing that further training. So this is going to be a huge shift again as well. So like I mentioned, we've got regulation in BC, but it's not really paramedic led. You could argue maybe it's paramedic supported, But what we really want to move to is a culture in paramedic self-regulation. So in BC currently there's 26 regulated health professions, but paramedicine still stands alone as itself as emergency medical assistance, and that's old language that we want to step away from, and we want to move to a self-regulated college or association that handles the professional practice of paramedics and speaks to all paramedics across the province, not just within BCEHS. And so current provinces and countries that have self-regulation in professional colleges are all there. We've got Alberta, Manitoba, Nova Scotia, New Brunswick, Saskatchewan, United Kingdom, Ireland, Australia and New Zealand, who just started their registration process within the last couple of months for national registration. So these are all countries that are ultimately working or have worked towards over a number of years paramedic-led self-regulation and professional colleges to champion paramedic practice. And in other countries that have advanced along, such as Australia and United Kingdom and Ireland, we've seen, well, and even Nova Scotia as well, we've seen the integration now of paramedics into other healthcare. Phone. Thank you. We've seen paramedics integrate into other healthcare areas such as community clinics, GP surgeries, the ED, working alongside nurses and doctors on a playing field that basically takes a team approach to providing patient care. So that's where we vision that we need to go with this, and the big way of achieving this is having paramedics drive paramedic practice. So in the same way that we're doing it for BCEHS, we need to take it up a level, and we need to move towards a professional college and association, and move over to a similar model. What's the one thing that we feel as a team that you as paramedics can do to support the organisation, to support these big changes to practice, and even support the move towards college? And I may have harped on about it a little bit during this presentation, but that is documentation. So we really need paramedics to ensure that they complete documentation on Siren to the best of their abilities, so we can look at that information. So the information that we get is only as good as the way that it's been completed or filled in. And the more that we can get of this, the more reports that we can run, the more data that we can capture, and the more evidence we have to make decisions with. I could give you the example most recently, just in the last day or two, there was a great discussion on the BCEHS Facebook op page about the need to provide PCPs potentially with better options for the care of patients who are having seizures. And there was a great thread kind of happening, and people having conversations. And again, ultimately, whilst it's kind of written down, it's anecdotal. We need to be able to see this information in the documentation. How many seizure calls are we going to a year? Where are these seizure calls based? Who's attending these seizure calls? Is it PCPs, or is it PCPs with ACP? Did it come down the CAD as a seizure? Did it come down as something else? What was the MPDS code? How can we track that information? All of that really helps build a big picture about one particular group of patients that we can then maybe look to provide better care for, with the expanded scope that we propose to EMELB. So right now, that's one of the biggest restrictions, is under PCP legislation, there's no ability to provide options for medications such as diazepam or midazolam for these patients. And the conversation comes up, well, how can parents do this? How can care providers do it? Simply, they're not licensed in the same way that you are. They've had those instructions come from their healthcare provider or from their physician, and they've had some training. We're just not allowed to do it under our licensure, which is why we propose the changes to EMELB. We've got a quick question here.
What process exists or will exist to request review of your documentation, to ensure that it's up to an appropriate level and to ensure that your checks and balances are in place?
No, that's a great question. we are working through this now with the quality team to look at what that process is going to look like. We want to ensure that all paramedics are getting their EPCRs audited clinically, so you're getting the feedback. So like I said, just starting this month and working into March, we are working on a quality tool within Siren for just initially 4 patient presentations that will give you your quality score immediately on completion of your paperwork. So if you've not filled out, if you've not filled out the required, I'm not going to say mandatories, because the mandatory fields are the minimum data set that we want to collect. These will be fields that we've assigned a framework to that defines what the best care for that patient should be, and at the end of your treatment will give you the score that you've got for how well you've documented. That doesn't mean to say that you've not missed something, in your clinical assessment. Maybe you've just forgotten to document it. And that will act as a learning tool and give you an opportunity to go back into that same EPCR and try and up your, I don't want to say score, but up whatever the performance indicator is. And again, from a learning perspective, no one's going to come in and say, oh, you've been consistently getting 50%. Well, they might do if you've not been improving your score. But if we provide you that opportunity in which to educate and learn about how to do it, then we can build a little bit of a culture of I don't want to say performance management, but a culture of learning where we can identify those individuals that are taking that information and actually turning it into better practice versus taking that information and maybe ignoring it the entire time. We've got another question.
I'm just wondering if there are certain areas where you can enter information, but a lot of people end up putting information in the comment section. So how is that going to, how can you possibly review that instantly?
So the narrative, will be more difficult to review, but what we'll be doing is attaching that quality assurance pieces to certain boxes. So for example, if you took an asthmatic or a COPD patient, we should all be auscultating their chests. So if you've not ticked the boxes under chest auscultation in Siren, then that potentially will give you a score that says, well, you've not told us that you've listened to the chest, even though you may have written it. It's in the narrative. We're going to be able to do some data collection and audit within the narrative, but really the predefined boxes is what's going to help us make the information clearer in reports. Does that help answer your question? Sure. So that's the immediate piece. The bigger piece after that is maybe utilising unit chiefs or utilising other employees where you could get a number of your patient report forms done, patient care records done per month. And even as the system matures and expands, we can look at peer review and peer audit as well, right? And kind of get paramedics into the mindset of looking at each other's work and openly critiquing it in an environment that's not belittling and in an environment that's encouraged of learning as well. So you could review my patient care record, I could review yours, and you give me honest and open feedback, and we just build that in terms of good communication. So just last half an hour, we've had some great questions so far. We were hoping, obviously myself, Oli, and John were able to field some questions. So between me and John, we want to open up the floor to discussion and questions from anybody that's joining us online or at any of the other sites. If there's anything that you disagree with or you find contentious or you want to expand into, we want this to be a safe place. So please feel free to jump in.
So Leon, while we're waiting for a question, I just want to touch on documentation too, and just stress the significance of accurate documentation and how it ties in with QA and QI and all these initiatives that we're pushing forward. When we have the correct and accurate documentation on this, we can better assess, are we actually affecting change in the right direction? Is this new initiative better than what we were doing before? So we really need to collect that data And we're in this incredibly unique position in BCEHS that we have enormous numbers to deal with, which is unlike many other pre-hospital care providers. Because we're on a province-wide platform, we can, for instance, just to throw the numbers out there, we can look at 65 opiate overdoses a day, and we can collect data from that. We can look at an average of 10 cardiac arrests a day and look at the management there. So we have these huge numbers, and with research, of course, the weight of the evidence in the research is directly related to the number of patients involved in that. So we're in this incredible position that we have huge volume of patients that we can document information on. And as far as driving paramedic practice forward, this is the key to driving practice forward, is getting that accurate documentation.
Agreed. Thanks, John. I'm probably just tying that into our responsibilities as a licensure holder is that we need to be ensuring that we complete the documentation good, because it's not just a requirement of the employer, it's a requirement of your license as a paramedic. And it is ultimately as well some patients, maybe a family member's patient care record. So it informs part of somebody's health history in this province, which other healthcare providers are going to be looking into. And again, if we want to raise those standards, we want to make sure that when physicians look at this paperwork, when nurses look at the charting, or anybody else, it's really, really good, and we can demonstrate how we're clinically responsible for these patients in a good way, and we get the buy-in from other stakeholders. Any questions online?
I'm just kind of trying to figure out how I wanted to word this. But further to John's point, with our enormous system and with the amount of data that's available to collect and record, is there a contingency in place at a management level that recognizes that with more documentation and with these paramedics interpreting and providing a more clinical role, is there a contingency in place that would permit more time to do this? For instance, I take great pride in my documentation. It does take me a little bit longer. And then on the radio, for instance, there's calls holding, calls holding, calls holding. Is there a correlation between mitigation at a dispatch level, where we're triaging these better with the Manchester triage system and utilizing our resources better in order to facilitate more time for the end practitioner to ensure that we are hitting all these boxes? Perhaps that's more of a convoluted way of asking the question, but
it is a good question, and there's all of those things that you've mentioned there. The clinical resource model, so the different way in which we're utilizing resources, setting ambulances to the higher acuity calls quicker, and streaming out those lower acuity calls into other alternative care pathways is freeing up that capacity. And all those things, before Siren was implemented again, before I joined the organisation and before John and Ollie were part of this team, all those things will have been taken into consideration as part of the implementation of Siren. We know that it's a tool and a software that will take people some time to get used to, particularly in the lower call volume areas where you maybe not using it as frequently or as often. But it is relatively intuitive software, and we know that over time the process will become quicker and the standard of documentation won't drop with that. You'll still produce good documentation, but as you use the system more, you'll be able to do it. You'll be able to do it quicker, and those things have been considered as part of that.
Yeah, I think less so of the bricks and mortar of using the actual system itself. I think, like you said, I agree with you in the sense that as you learn the system, it will become more intuitive. My thinking is more so as the profession changes, as we move from this kind of you call, we haul mentality to a person who's taking an invested approach in their patients, and they're expanding their documentation, and our scope of practice is growing. At an institutional level, are we making provisions for that as the role changes, the resources will be more resources will be required, and the way that we utilize our resources are going to drastically change. Right?
Yeah, and I think the team that it's involved in part of that analysis and that study, they've been going to these areas and they've been looking at all that information, and the introduction of more resources, I think most recently in the interior, is part of that plan, right? So, okay, let's look at the resources, let's look at the demand, let's look at all the things impacting that, and is there opportunity to create more positions? And that was done with those PCP positions in I think, Kelowna most recently, and across other parts of the province. So, yeah, and in relation to some of the C-treat and non-transport stuff, there's various studies that actually talk about. We always get quite time-focused, when we may need to be more care-focused. But actually, sometimes leaving people at home isn't the quickest thing to do. Sometimes, taking them to the hospital and dropping them off is the quickest thing to do. But is it the right thing to do? And that's the biggest question. Kind of ultimately, we're there to provide good care and ensure that a patient's experience and journey is the best that it possibly can do. And if that means we're spending the same amount of time as driving somebody to hospital, handing over, clearing, and then driving back, not really kind of part of our conscious decision at that time. It's just what's the right thing for this patient. Any other questions? John, anything you want to add? Or Devin?
Yeah, Leon, I'd like to add to that because I think he brings up an excellent point. And, we're moving forward. The short answer is we have to find ways to work around this, and we have to find ways to allow paramedics time to accurately document, because our past practice is unacceptable. And I've been part of that past practice where I've been in emergency, filling out my Form 2, and those calls have been holding, as you pointed out, and I just leave the form and I respond to another call, and I come back, and now I have 2 forms to fill out. And that patient documentation needs to be done at the time the patient is delivered, and it needs to be delivered with that patient for continuity of care. So it isn't acceptable practice to have inadequate documentation and to be rushing off to do other calls. So, and as Leon said, sure, the use of this platform will get easier with the higher volume, but it's the higher volume that's the problem. You're doing more calls, so you're more comfortable with the platform, but you're in a high call volume area, so that creates a problem in itself. And in the low call volume areas, being called out of the hospital isn't an issue, but it takes you much longer to do your documentation because of just lack of familiarity. So, yeah, we're going to have to come up with initiatives to deal with this process, because the call isn't finished until that accurate documentation is complete. So I don't know if that answers your question, but it certainly supports your concern.
Yeah, definitely. I think the question is largely open-ended. There's a number of ways to interpret it, but it definitely fortifies my thinking. I appreciate it.
Any other questions online? Devin, is there anything else that you'd like to add, or any questions from anybody in PG?
No, nothing to add, Leon. I think your and John's summary there was excellent, and I totally agree. Documentation is crucial, and I really appreciate when a crew has, if I'm working in emergency, if has documented well, helps me tremendously and helps the hospital through the hospital journey.
Great. We've got another question down here.
Kind of a question, comment. How can it be put out there to the rest of coworkers? The documentation is important, because I've actually been pressured to finish documentation, and they're told, well, there's 10, 15 minutes, we're going to get an offload delay, and people are getting anxious.
I say, and the pressures come from your partners. Mm-hmm. It's a good question. So it was basically just asking about how we deal culturally with the practice that John mentioned, that maybe exists where people feel pressured to speed the paperwork up or clear without completing it. And I think the simple answer ultimately is that we want to empower you to be able to say no. If you're facing that practice or that behaviour with people that you work with, then we want you to have the ability to confidently turn around and say, no, you want to complete this paperwork. It's your license. It's not their license. You took care of this patient. As a team, you both took care of this patient. And that you want to ensure that you get it done. If dispatchers on the phone or the UC or one of the area managers is on the phone talking to you about turnaround times, whilst we know it's a consideration, it's something that we need to build into the siren use. And for now, accept that that's the lay of the land until people become more familiar with it. But you shouldn't be feeling pressurized into completing your documentation. And if you are, I would encourage you to reach out to one of us or one of your paramedic practice educators or even part of your local leadership team and let them know that you're experiencing those things. Anything to add to that, John?
No, that's good. Thanks, Leon.
Okay, everyone. Unless there's any more questions, it's 20 to 12. I hope you've enjoyed the presentation. I hope you found it insightful and informative. If you've got any questions for us in the team, our email address is clinicalpractice@bchs.ca, as John mentioned earlier on. This is an inbox account that's monitored by all of our team members. We'll do our best to get back to you, usually within 10 business days. And it can be on anything clinical practice related or paramedic related. Even if we don't know the answer, we'll loop you in with somebody that does know the answer, be it a PPED or a manager, and do our best to get a response to you. It's a platform that's been working well so far. We sometimes include the questions as part of our clinical practice update document, so we can share those questions and the responses with everybody else around the province. If you're not aware of the clinical practice updates, they are coming out monthly currently. They get pushed out on the BCEHS handbook, and they also get pushed out on BCEHS SnapComs as well. So we are working on other initiatives to try and build communication channels to share this information. We're always open to ideas and suggestions as well. Each one of us is on Twitter. We're actively engaged on there. You can follow us and see what we're up to and look at discussions and look at research and practice online. If everybody is happy and there's no further questions, then we'll conclude these UBC rounds. Hope you all have a good Christmas and a New Year. We'll be back in January.
Thanks, Leon.
Hi, Leon. This is Lucian from Prince George. Can you hear me at your end?
Yeah.
Hello.
Hello, we can hear you.
Hi, it's Lucian here. I've lost my audio. Okay, I've lost my audio several times, but you may have answered this already. Two things. Crew members were just wondering when the T-pods will actually be available in the stations for them to use. And the second question was for the practice educators who have trial stations for the Penthrox. Have you got a confirmed date when the educators will be getting the training for the Penthrox and the supplies to go with it so we can start delivering it to our trial stations?
So two great questions, and unfortunately Oli's not here to be able to answer them. In relation to the T-pods, I don't know if John might be able to jump in on that one. What I can tell you about Penthrox is that Oli's still working through that plan, and that once the final pieces have been put together, then he'll be going out and engaging the PPEDs in those regions where Penthrox has been identified as part of the trial group. That's more than likely going to be the new year now.
Okay, that'd be great, because we're just trying to tie in all the travel arrangements around mental health courses in some of these trial station areas. So if we can cover two things in one trip, that would be fantastic. But we'll wait till we hear back from Oli. Thank you very much.
Not a problem. Any other questions? Okay, great. Thanks for joining us, guys. We'll see you in the new year.
Good. Thanks, everyone.